to the previous one, to the previous slides. Sorry, I didn't. Yes, so and then we're going to do live Q&A, and we're going to try our best to respond to as many questions as possible, and then we'll close the session. Okay, next slide. Okay, next slide. Okay, so I'm going to briefly go through the introduction. Next slide. Okay, so this is the diabetes atlas from the diabetes map from Diabetes Atlas from International Diabetes Federation, which is published every 2 years probably. And as you all know, that more than 50% of diabetic patients are Asians. It's obvious because a large number of people are actually living in this region. Next slide. So actually the numbers are in Southeast Asia, 8.8% adults have diabetes and 87.6 million have diabetes. And this is the second highest in IDF regions. And this will rise to 152.8 million by 2045. And more than half have not been diagnosed and are at a higher risk of harmful and costly complications. And second highest number of deaths due to diabetes are in this region. And this is the second highest among the IDF regions. Next slide. And in Western Pacific area, 9.6% of adults have diabetes. And 162.6 million have diabetes. And this is highest in IDF region and represents 35% of the world's total number of adults with diabetes. And 1.3 million deaths due to diabetes among adults occurred in this region. And this is the highest in IDF region. Next slide. So we now knew that how serious these problems are. And from the literature and from the recent analysis, we all know that approximately 50% of people with type 2 diabetes still die from cardiovascular disease. So today we gathered together to discuss about how we can manage our patients better to prevent cardiovascular disease. Next slide. Okay, so I'm going to briefly introduce today's first speaker, Professor Mark Cooper. Professor Cooper is the inaugural head of the Department of Diabetes Central Clinical School, Monash University, Australia. And he is an endocrinologist, and his main interest is diabetes complications, especially kidney disease. And he has won many excellent awards from EASD and ADA, and he has over 500 peer-reviewed publications. And I'm greatly honored to invite Professor Cooper as a speaker. Please welcome Professor Cooper. Professor Cooper, please.
Thank you very much. It's a great pleasure and honor to be able to give you a presentation on this topic. And we've already heard about the importance of cardiovascular disease in diabetes. I'm going to review how we can manage these patients better. And I think over the last decade, we've had some major advances that really have helped very much the diabetic patient with or at risk of cardiovascular disease. So these are my disclosures, which include support from Boehringer Ingelheim, where I've worked on some of the important trials as well as giving lectures. So what I'm going to first do is talk about a case study of a patient with type 2 diabetes, and in particular address the problem of multiple risk factors which accelerate the problem of cardiovascular disease in the diabetic patient. Then going to talk about how we control glucose, look at some of the classical trials, and then some of the newer agents, which we'll hear more about in the subsequent talk, particularly SGLT2 inhibitors. I'll then review where we are with blood pressure control, talking about not only the renin-angiotensin system, but also aldosterone, particularly with the recent data with finerenone. A little bit on lipid lowering, which is clearly also moving. And finally, talk about how you put all these together, where we have some data, particularly from the STENO study. So it's very important to appreciate that many people will already have cardiovascular disease before they're diagnosed with type 2 diabetes. There's a clustering of risk factors. And so a lot of the people already have hypertension or dyslipidemia. And then they'll already be developing atherosclerotic disease. Then they'll develop diabetes with the development of microvascular complications. And the diabetes duration will accelerate these complications, in particular macrovascular complications. And increasingly, we appreciate that there's a very close link between the kidney and cardiovascular complications. So if we look at the life expectancy of someone aged 60, you can see here that a person that doesn't have diabetes or cardiovascular disease has at least 20 years plus in most countries of a normal lifespan. However, if you develop diabetes, you reduce your lifespan by 6 years. And if you also have cardiovascular disease, that doubles to 12 years. So let's look at Mr. Lee. He's an Asian male, aged 60. His weight 70 kilograms. His BMI is modestly elevated, but would be considered overweight in the Asian population. Blood pressure is 135 on 85. He's been diagnosed with type 2 diabetes for 5 years and is known to have stable coronary artery disease. When we investigate him, he has moderate diabetic control, probably suboptimal at 8.2%, and clearly has not achieved the target of 6.5%. Lipids reveal a modest elevation in cholesterol with an LDL cholesterol, which would be within the normal range, but is probably not appropriate in someone with stable coronary artery disease. And finally, they have a reduced GFR, but still not in severe renal impairment with microalbuminuria. So what would we do in this patient? Well, this patient has a range of risk factors: suboptimal glycemic control, blood pressure is probably not ideal, particularly in the setting of microalbuminuria, and we'd probably want to achieve a better LDL cholesterol lowering because they already have established cardiovascular disease, and clearly their weight is probably modestly elevated, particularly in the setting of type 2 diabetes in an Asian patient. And we have a whole range of treatments on the right of this panel that I will talk about in more detail. So the first thing to appreciate is that we are not really achieving good glycemic control in most of our patients. We want to achieve at least 6.5%. Even if we had a less strict target of 7%, only about a third of patients are achieving that level. And over 65% have very poor control. And over 8%, at least 60 to 70%. Furthermore, we know if we look at patients who are already on metformin, there is a degree of inertia in the way we treat these patients. And the longer you wait on metformin, the less likely it is that you will achieve a hemoglobin A1C of less than 7%. So the natural history of diabetes is that it's a progressive disorder and that you need more and more treatment to achieve good glycemic control. And by not having good glycemic control, you are stimulating, promoting the development of complications. We know there is inertia. This is a very nice series of studies by Dr. Kunti from Leicester in the United Kingdom, who has shown, particularly in general practice, that we often delay commencing treatment. So you might have a patient originally on one oral agent. When their diabetic control is still not very good, you consider adding another agent, but you often wait for up to 3 to 7 years before you would add a third agent. And then there's a further delay to consider insulin. And now with these injectables, which are often now being given with insulin, there's a further delay. So you have a prolonged period where you have inertia and you're not aggressively treating the diabetes. So what can we do? Well, I'm going to talk about the different situations and risk factors that we need to treat. Well, of course, this is diabetes. So the first thing we need to do is treat the glucose. And we know from the clinical trials, the aggressive glucose-lowering trials, that the effects on cardiovascular disease have not been that impressive. So if we look at the classical study, the UK PDS, newly diagnosed patients we saw a very nice reduction in microvascular, but the cardiovascular disease often took time, and mortality wasn't seen initially in the study. The ACCORD study, a subsequent aggressive glucose control study, again, we saw this nice reduction in microvascular complications, and indeed there was an increase in mortality, which is not fully explained. At about the same time, with quite a similar study, the ADVANCE study, which had a very significant number, more than a third of Asian patients, again, we saw this great benefit on microvascular complications, but the cardiovascular complications were unaffected and no effect on mortality. And again, with the VADT, the veteran study, again, good effects on microvascular, but the effects on cardiovascular were pretty disappointing with conventional glucose-lowering agents. And if we look, for example, at the ACCORD study, you can see here that there was an increase in death, and this was attributed mostly to an increase in cardiovascular death. Interesting, there was a trend towards a reduction in non-fatal myocardial infarction. So glucose control is probably having some benefit on the atherosclerotic process. But ultimately, this does not translate to a reduction in death, which may be related to other cardiovascular issues, such as heart failure or the possibility of hypoglycemia, which is often seen with this intensification using conventional drugs. If we look at the ADVANCE study, for example, you can see no effect on major macrovascular events, standard versus intensive, and the positive benefit is the effect on microvascular events, which was primarily renal rather than retinopathy. So if we look at these studies and we look overall in a meta-analysis of glucose lowering, what we see is that there is a renal benefit, but it is primarily new onset microalbuminuria or the progression of micro to macroalbuminuria. Those hard endpoints like low GFR, doubling of serum creatinine, end-stage kidney disease, there is a modest trend, but it is a modest effect and probably not statistically significant. If we look at patients with respect to heart failure, you can see with all those studies, the overall hazard ratio is 1, emphasizing no benefit on heart failure with intensive glycemic control. So how can we manage type 2 diabetes? The conventional agents haven't really delivered a lot. A modest effect on microvascular complications, no effect on heart failure, and at best, a very modest effect on atherosclerosis. So we know diabetes is caused by multiple factors, primarily effects on insulin secretion, also some abnormalities in the endogenous antagonist of insulin, glucagon. There is insulin resistance, and this is reflected by increased hepatic glucose production and reduced glucose uptake and an increase in lipolysis. There is also an incretin effect where there is an abnormality, particularly in the functionality of the GLP-1 and GIP axis. There is also some central factors. And finally, there is an alteration in glucose reabsorption. And by having this reduction in this increase in glucose reabsorption, we end up promoting systemic hyperglycemia. So the most exciting area has turned out to be the new results with the SGLT2 inhibitors. And the EMPA-REG study really transformed the way we thought about glucose lowering, because not only were we looking for glucose lowering that had added benefits like improved glycemic control or weight loss, but we saw a benefit on cardiovascular disease. And you can see overall, there is a modest effect on cardiovascular disease, primarily driven by the results in the EMPA-REG and CANVAS, and also in the CREDEN study. And what it appears is primarily the impressive effect is in those people who already have cardiovascular disease or have some degree of renal disease, as was seen in the CREDEN study. But the really spectacular effect was on heart failure. And here we saw great uniformity among the 5 studies, with a heterogeneity level of 0, indicating that all the results were very consistent, with hazard ratios between 0.6 and just over 0.7. So clearly, this is a class of drugs very impressive in reducing heart failure. And although I won't talk about this in more detail, it turns out these drugs are also useful in the non-diabetic context as well. And if we look at the renal data, when we use the same composite outcomes, we again see very consistent results. Now, it's important to appreciate that in the primary papers of these trials, there are differences in the hazard ratios because they've used different kidney composite outcomes. But if you use the composite outcome that includes sustained greater than 40% reduction in eGFR, all the studies are ranging between 0.53 and 0.66. So if we look overall at all the trials with SGLT2 inhibitors and type 2 diabetes, we see in particular a nice reduction in 3-point MACE in several of the studies, a reduction in cardiovascular death only seen in EMPA-REG, very consistent results with respect to heart failure, and in general, excellent results with kidney outcomes, noting that the outcomes in the Virtus study were different, but if you use the same parameters as in the other studies, you also saw a nice reduction in kidney outcomes. What about GLP-1 receptor agonists? Well, here we have very nice data on microalbuminuria, and here you can see very nice effect from the cardiovascular outcome trials. With respect to renal endpoints, if you look at development of macroalbuminuria, again, there is a trend. The ELIXIR study is a bit different to the rest, but that was a study using a very short-acting GLP-1 receptor agonist. But you can see here we've seen nice benefits. And there is a more recent paper that just was published in the New England with another GLP-1 receptor agonist showing very similar consistent results. So we've got now two classes of glucose-lowering agents that do more than just lower glucose. They do improve cardiovascular outcomes. And we will see increasingly in the guidelines a focus using some of these agents. So the current guidelines from the ADA, published earlier this year, indicate initially metformin. But if the patients have cardiovascular or renal disease, independent of their A1C or use of metformin, we would consider with atherosclerosis, a GLP-1 receptor agonist or an SGLT2 inhibitor. In heart failure, we would go first for the SGLT2 inhibitor. And if the patients have albuminuria, you would go first for the SGLT2 inhibitor and then consider adding a GLP-1 receptor agonist, particularly as an add-on or if the SGLT2 inhibitor is not tolerated or contraindicated. And in the patient with albuminuria, but no diabetic kidney disease, we have increasing data, particularly with the SGLT2 inhibitors, that these agents can also be used. Well, we have other risk factors in this patient, including blood pressure that is borderline elevated. And this was really transformed more than 20 years ago when the Renal study showed with losartan a reduction in doubling of serum creatinine, and this translated to a reduction in end-stage renal disease. At the same time, there were similar data with another A2 antagonist, irbesartan, the IDNT trial, consistent with the findings of that study. And this was the first time that any drug in diabetic kidney disease had been shown to postpone end-stage renal disease. And in patients with microalbuminuria, you can see here at about the same time, in a dose-dependent manner, the A2 antagonist irbesartan was associated with a reduction in albuminuria, and this was not as impressive in terms of creatinine clearance. We've had a major advance in the last few months with a mineralocorticoid receptor antagonist, finerenone. So we already had data with spironolactone and eplerenone that these drugs were anti-albuminuric. But unfortunately, in type 2 diabetes with nephropathy, these patients are at high risk of elevated serum potassium. in part due to type 4 renal tubular acidosis. So we need a mineralocorticoid receptor antagonist that has less hyperkalemia. And finerenone, a non-steroidal mineralocorticoid receptor antagonist, has recently been shown not to have as high a prevalence of hyperkalemia. And you can see in the initial study, the pilot study with the ARTS-DM, you can see here that as the finerenone dose increased, we saw a progressive reduction in urinary albumin excretion, justifying that it was worth doing larger studies with this agent. And indeed, we now have data, the Fidelio DKD study, showing that this agent is able to reduce by 18% the composite endpoint of end-stage kidney disease. Now, I haven't shown you, but we have data now, sub-analyses, showing even in the patients receiving GLP-1 receptor agonists or SGLT2 inhibitors, the benefit of finerenone persists, indicating that this is an add-on to conventional treatment, including RAS blockade. And you can see here there was also the extra cardiovascular endpoint, a composite of cardiovascular death, non-fatal infarct, non-fatal stroke, or hospitalization for heart failure, which was statistically significant, of 14% reduction. And finally, further renal data is shown by the very impressive reduction in urinary albumin excretion of at least about 30%, which is an add-on to the other drugs they're taking, including renin-angiotensin system blockade. And if you look at the GFR data, you can see there's an acute reduction in GFR, which is often seen with drugs that act hemodynamically. We've seen it with RAS blockade. We've seen it with SGLT2 inhibitors. But ultimately, we're seeing an improvement in the GFR slope of at least 1.3 mils per minute per year. And if we then look at blood pressure lowering overall, and this is conventional blood pressure lowering, you see reductions in mortality, cardiovascular disease, coronary disease, heart failure, but in particular, a very nice reduction in stroke, a condition that is underappreciated and is common in the diabetic population. So in summary, we have new data with these mineralocorticoid receptor antagonists. Both the first and second generation saw effects on albuminuria and cardiovascular outcomes, but there was the problem of hyperkalemia. Fidelio is a third generation mineralocorticoid receptor antagonist trial with finerenone, and we saw very positive effects on kidney-related and cardiovascular outcomes. And although there was an increased risk of hyperkalemia, it was nowhere near as high as had been seen in previous studies. Now, since that time, there has been preliminary results with another study with finerenone, also showing similar benefits, and we look forward to hearing more about the positive results from the other study, the Figaro study. What about lipid lowering? Well, we already have very convincing data that statins are very useful in the diabetic population. And here I'm showing you a range of studies where you have diabetics and non-diabetics. And in general, the diabetics do as well as the non-diabetics in reducing cardiovascular risk. But we know that statin therapy is often not enough. There are side effects. We are unable to achieve the best control. But we are fortunate there are a new class of drugs, the PCSK9 inhibitors, and we've had some studies, and I'm just showing you one, where we have these high cardiovascular risk patients, and about a third of them had diabetes. And you can see with this class of drugs, we're seeing very nice reductions in LDL, ApoB, total cholesterol, triglycerides, a rise in HDL, and importantly also a risk factor that has been difficult to treat previously, a 27% reduction versus placebo of lipoprotein(a). How important this will be for reducing cardiovascular risk in diabetes requires further studies which are currently in progress. So I've shown you data, benefits of glucose lowering, particularly with SGLT2 inhibitors, and GLP-1 receptor agonists. I've reviewed the situation that blood pressure reduction delivers something, particularly with RAS blockade, and there's some very exciting data with the mineralocorticoid receptor antagonists, and there are also modest blood pressure lowering effects with SGLT2 inhibitors. And finally, I've commented on lipid lowering, where there's been a lot of advances which are potentially going to deliver even further cardiovascular risk reduction in the diabetic population. So we already know from the STENO2 study, a study where they were aggressively addressing a range of cardiovascular risk factors that you can see here, now followed initially for 8 years. There was a group that received conventional versus intensive. And then we followed them for another 12 years. And you can see after 21 years, we've seen almost a 50% reduction in death or cardiovascular disease, indicating that there was a memory of that 8 years of very good intensive treatment has delivered a long-term benefit. And this just shows you what were the differences. We saw big reductions in blood pressure, both systolic and diastolic, very nice effects on LDL cholesterol, an effect of 0.7% on hemoglobin A1C, common to what we see often with monotherapies. There was no difference in BMI, and there was no difference in reduction in smoking. If we look long-term at the GFR decline, we see a very modest difference in the reduction in GFR, which ultimately ends up a difference of maybe 0.8 mils per minute per year. And in terms of the albuminuria, we see nice reductions during the intensive treatment, but unfortunately over the next few years, the albuminuria starts to catch up, so that after 12 years off treatment, there's really no difference in urinary albumin excretion, emphasizing that the multifactorial intervention, although beneficial, needs to be sustained for long-term benefit. So in summary, in a patient like Mr. Lee, contemporary clinical practice involves treating all risk factors. We need to lower the glucose, but in particular, we need to consider the newer agents, the SGLT2 inhibitors that have very dramatic effects on heart failure and renal disease, the GLP-1 receptor agonists, which appear to be anti-atherosclerotic and have some renal benefit, but do not improve heart failure. We need to consider blood pressure reduction, not RAS blockade, but RAAS blockade, and more we'll need to consider adding agents such as finerenone. And we also need to consider the role of SGLT2 inhibitors that also have some blood pressure effect. And finally, we need to consider even more aggressive lipid lowering. And I didn't even talk about ezetimibe, which has also been shown to have benefits in the SHARP trial. So I might stop there and thank you very much.
Well, thank you, Professor Cooper, for your excellent lecture on how to prevent our cardiovascular risk factors. Okay, next it's my turn. So I'm going to share my slides. Okay, thank you. So, okay, so the title of my talk is The Value of SGLT2 Inhibitor in Type 2 Diabetes with Atherosclerotic Cardiovascular Disease in Asian Perspective. Okay, so these are the contents that I'm going to tell you about today. First, I would like to briefly go through the burden of type 2 diabetes, which is connected to the previous 3 slides that I've already shown you in the introduction part. And second, I would like to discuss about the effects of SGLT2 inhibitor and the prevention of metabolic and renal cardiovascular disease. And the last part, I will wrap up focusing on the advantage of using SGLT2 inhibitor in Asian population. Okay, so connecting this slide with the previous 3 slides explaining about the diabetes burden in Asian region, the more serious part is that there are a huge number of people with undiagnosed diabetes in this region. So we say that there might be a similar number or even more of the larger number of people with undiagnosed diabetes in this region say it's like a tip of an huge iceberg. So accordingly, in this region, from 20 to 30% of the patients with diabetes already have the complications, for example, microvascular and macrovascular complications, which will lead to very serious problems. And also another serious problem in this Asian region is that there are increasing number of young onset diabetes, and this young onset diabetes people will have more central obesity, and also they will have more prevalence of hypertension and other cardiovascular risk factors, which will lead to more increased medical burden for diabetic complications. From now on, I would like to briefly introduce the diabetes fact sheet in Korea. So Korean Diabetes Association releases diabetes fact sheet every year or every 2 years. This is the prevalence of diabetes in Korea. So the Korean adults 30 years or older have, 13.8% of Korean adults 30 years or older have diabetes. So this is the prevalence of diabetes in Korean adults. And more serious problem is that 27.6% of Korean adults with 65 years or older have diabetes, which means 1 in 3 Koreans already have diabetes. So Korea is aged society already, and it's headed to the super aged society. So there are too many population of older people. So this is a very serious problem. And this prevalence increases as they get older. And for example, for men, already in their 40s, 13% of them already have diabetes. And for women, the prevalence increases as they get older. And after menopause, this prevalence almost overwhelms that of men. This diagram is showing what proportion of patients with diabetes accompany the comorbidities or cardiovascular risk factors such as dyslipidemia and hypertension. So the proportion of diabetes only treated patients is only 14.8%, which means most of the diabetes patients in Korea would have other cardiovascular risk factors such as hypertension and diabetes. Another problem is the Korean diabetes patients are becoming more obese. So this pink part is the diabetes patient with normal BMI, and this orange part is overweight. So half of the Korean diabetes patients are obese, but it was totally different around 20 to 30 years ago, but they're getting more and more obese. And another serious problem is that class 3 and class 2 obesity, the patients with class 2 and class 3 obesity is markedly increasing. This is the diet fact sheet that's showing the diabetes complication, especially cardiovascular complications. Although the proportion that this cardiovascular disease comprises among the complication is kind of decreasing, as you could see here, and the proportion of heart failure is increasing. Still, the major cardiovascular disease such as ischemic heart disease and ischemic stroke is very high. The prevalence for these major cardiovascular diseases is pretty high. And for the nephropathy in Korea, the prevalence of nephropathy is very rapidly increasing, and the patients who have renal replacement therapy is rapidly increasing. So Korea is kind of top 7th country in the world who have the most highest instance for new renal replacement therapy. This is my own study. So what I did was that in over 6 million Korean adults who performed national health screening in 2009 and followed up until 2016, I wanted to analyze whether having diabetes and comorbidities with diabetes would increase the mortality in Koreans. And if you have diabetes, whether you have comorbidities or not, the mortality risk would definitely increase. And if you have diabetes and at the same time coexisting diseases such as coronary heart disease, ischemic stroke, and estimates GFR, chronic kidney disease, you have significantly increased risk for mortality. So from the literature and from the recent analysis, we all know that approximately 50% of people with type 2 diabetes still die from cardiovascular disease. So what are we gonna do for this? So actually, probably, unfortunately, or especially, cardiovascular disease exists as a continent. It does not happen at one day. So patients are at increased cardiovascular risk throughout their lives and throughout the pathophysiological course, even before diagnosis. So first, they will have risk factors such as diabetes and at the same time hypertension and dyslipidemia, and then they will go into subclinical stage and then clinical damage to their arteries and vessels, and the event will happen, which will lead to the increased mortality. So if we do something around here and cut off the vicious cycle, then we could prevent the event. For the second part, let's see what SGLT2 inhibitor could do to prevent metabolic and renal cardioprotection. So SGLT2 inhibitors acts through the inhibition of reabsorption of glucose and sodium in the proximal tubule of the kidney, in which in turn increases glucoseuria and natriuresis, which will lead to reduction in systemic volume and glucose and sodium. And this will lead to lowering of blood glucose and blood pressure and body weight and decrease the glucotoxicity. Another unique mode of action of SGLT2 inhibitors is it acts through insulin-independent mechanisms, just like insulin sensitizers. So in comparison to sulfonylurea or GLP-1 receptor agonist, which acts through the stimulation of beta cell to release insulin, this SGLT2 inhibitor acts an insulin-independent mechanism. So we could combine SGLT2 inhibitor with other drugs that acts through insulin-dependent mechanism. It will act very well. But it doesn't mean that we could use this drug in patients with type 1 diabetes or type 2 diabetes with long duration with very low insulin secretory function, because it will lead to increased risk for glycemic ketoacidosis. This slide is showing the effects of empagliflozin 10 milligram and 25 milligram in combination or in monotherapy with other drugs. So regardless of the drug combined, empagliflozin shows from 0.6 to up to 0.9% reduction of HbA1c. So it's kind of a pretty strong drug for glycemic control. Well, we cannot talk about any prevention of cardiovascular disease of anti-diabetic medications, not referring to EMPA-REG outcome trials. So the amazing part about this EMPA-REG outcome result was that this actually happened on top of standard of care. So they treated these patients with type 2 diabetes and established cardiovascular disease from 42 countries and more than 70,000 patients around the world with empagliflozin and saw the cardiovascular events. And this was done on top of standard of care, which means more than 70% of them were already having statin and more than 90% were already having antihypertensive drugs with a relatively short duration of 3.1 years. And the empagliflozin treatment in these patients resulted in 14% of 3-point MACE reduction, a 38% reduction of cardiovascular disease, and 32% reduction of all-cause mortality, and 14% reduction of hospitalization for heart failure, and also 39% reduction of nephropathy. And I think the most amazing part is the reduction of mortality, because actually treating our patients with this drug would actually save their lives. Okay. So let's see the Asian data of EMPA-REG outcome. First about the cardiovascular outcome. Okay, so whether they are Asians or in overall population, these Asian patients also showed similar or more stronger results, effects on the cardiovascular prevention. And another point that we have to focus on is the actual event rates in these patients. So in overall, Asians have lower incidence and event rates for other all-cause mortality and cardiovascular outcomes. But actually, for stroke, Asians have higher prevalence or event rates for stroke compared to overall study population. But anyway, they showed similar results for the cardiovascular prevention with this drug. Okay, so for individual components for 3-point MACE, they showed 32% reduction for 3-point MACE with empagliflozin treatment. And this difference actually happened very early in the trial. And also for 56% reduction for cardiovascular death. And also this happened very early in the trial. And for heart failure hospitalization or cardiovascular death, very similar, but actually this heart failure hospitalization was not significant because the actual event number was small in this group. I think that was the reason. Anyway, they showed very similar results in Asian patients. And for cause mortality, similarly 36% reduction, and this was evident in early of the trial. Okay, let's look at the kidney outcome in Asian patients in EMPEROR outcome trial. So for kidney outcome, you could see that from all these endpoints, they show similar or probably a little bit stronger in patients with Asian patients. So similarly, we could focus on the actual event rate of renal disease in Asians. So Asians tended to show a little bit higher event rates compared to overall population. So for the worsening, let's see, the event of instant or worsening nephropathy in Asian patients, they showed 36% reduction for Asian subjects, and it's pretty similar to the overall population. And for the progression of to microalbuminuria, they also showed 36% reduction. And for the eGFR, you could see that although there was an initial dip of the eGFR due to the reduction of systemic volume, the empagliflozin actually maintained the eGFR through the study. It's a very safe drug. Okay. And this graph is showing the eGFR at baseline and last value on treatment and at follow-up in the subgroup of Asian patients. And you could see that this eGFR is pretty continuously maintained in Asian patients, in patients with empagliflozin compared to placebo. Okay. In the last part, I would like to talk about the advantage of using SGLT2 inhibitor in Asian population. This is the cartoon actually from my own review article published in Endocrinology and Metabolism in 2015. So the Asians tend to have decreased insulin secretory function relative to insulin resistance due to small pancreatic beta cell mass, and also propensity for visceral obesity within same BMI. And also for complications, they have increased risk for ischemic stroke compared to the Caucasians, and probably relatively lower instance of coronary heart disease, and also increased risk for nephropathy. And there are a tendency of increasing prevalence of young age onset diabetes. Okay. So I'm not sure if you had any experience to see this paper. And this was in the right panel. This study was published in Lancet Diabetes Endocrinology, performed by Professor Kyung-Soo Park in Korea. And what they did was in 4,000 people without diabetes at baseline, they performed OGTT for 10 years, every 2 years for 10 years. And they looked at the changes and trajectory of beta cell function and insulin sensitivity. And compared to those who did not progress to diabetes, those who progressed to diabetes actually showed less compensatory increase of insulin secretory function relative to decreasing insulin sensitivity. And in the left panel, this cartoon was actually published as an editorial from the Japanese group. And compared to the Caucasians who have compensatory function for insulin secretion in relative to insulin sensitivity, the East Asians have low compensatory function for insulin secretory function in relative to decreasing insulin sensitivity. And this is the main mechanism for the development of diabetes in Asian patients. Okay, so to reduce or protect the beta cell function for a long time in our patients with diabetes, we have to control our metabolic risk factors, such as we have to decrease the glytoxicity. So we have to lower HbA1c. So this table is showing the effects of SGLT2 inhibitors for the metabolic risk factors. So SGLT2 inhibitors as a class effect, have this strong glycemic glucose lowering effects, and also it has the ability to reduce our body weight, and also it has the ability to reduce blood pressure, which will all lead to the improvement in metabolic risk factor, and also the for prevention of cardiovascular disease. Well, this is summarizing the cardiovascular outcome results of the SGLT2 inhibitors. So you've already seen from the Professor Cooper's slide, but I want to say if these are the results from the main trials, then we could adjust these results to Asian patients. So let's look at the proportion of Asian participants in these trials. So compared to the other trials with around 10 to 20% of Asian study populations, empirical outcome trials actually included almost 30% of Asian populations. So probably we could say that we could apply the result of empirical outcomes to the Asian patients more easily than other cardiovascular outcome trials of SGLT2 inhibitors. So there were meta-analysis comparing these outcomes in whites and also in Asians. So for maize, if we compare these two ethnic groups, Asians showed a little bit stronger, SGLT2 inhibitor treatment showed a little bit higher protection effects in Asian patients compared to white people, 12% around. And for cardiovascular death and hospitalizations for heart failure, around 27% more stronger effects of SGLT2 inhibitor for the cardiovascular death and heart failure in Asian patients. So probably from the result of this meta-analysis, we could say SGLT2 inhibitor might be more effective regarding these endpoints in Asian subjects compared to whites. For the last two slides, I would like to introduce the pharmacotherapy guidelines from Korean Diabetes Association, which was just published 2 months ago in the annual meeting this spring. So after lifestyle modification, we recommend the monotherapy of metformin. And then if this is the first algorithm in patients without any comorbidities. So first metformin, and then you could combine these many drugs. And we describe these drugs with 3 components: glucose lowering effect, hypoglycemic risk, and weight change. So with those short red bar and long downward yellow and green bars are the best drugs. So accordingly, SGLT2 inhibitor and GLP-1 receptor agonists are the best drugs. The second algorithm is for the patients who already have comorbidities. So we try to express it into patients with heart failure and cardiovascular disease and chronic kidney disease. So if their glucose is high, you combine metformin with SGLT2 inhibitor. But if the glucose is not so high, then you could just start SGLT2 inhibitor probably earlier than metformin. And then for cardiovascular disease, similarly, if the glucose is high, then you could start either SGLT2 inhibitor or GLP-1 receptor agonist. And we put TGD because TGD has the secondary prevention, cardiovascular disease prevention effects in proactive studies. So we put TGD in this algorithm. And for CKD, if the glucose is not so high, similarly to heart failure population, you could consider SGLT2 inhibitor first, probably earlier than metformin. And then if the glucose is high, then you could combine SGLT2 inhibitor or GLP-1 receptor agonist with metformin. Okay, so this is the summary slide of my talk. The number of patients with type 2 diabetes is markedly increasing in Asians, both in Southeast and Western Pacific regions. So burden of type 2 diabetes is heavy and will continue to get heavier in this region. And as the number of patients with diabetes increase, the burden of comorbidities accompanied by diabetes would get bigger, both macro and microvascular complications, and also the risk for mortality. And SGLT2 inhibitors show mostly ideal profiles for metabolic and cardiorenal protections in patients with type 2 diabetes, proven from the results of EMPA-REG outcome trials. And the results from sub-analysis of EMPA-REG outcomes show similar to or better effects of empagliflozin on cardiorenal diseases in Asian type 2 diabetes patients compared as the overall study population. So to summarize, empagliflozin could be considered as the optimal treatment option for Asian patients with type 2 diabetes for better protection of cardiorenal complications. Okay, that's all I prepared. So yes, it's time for live Q&A. And I think we have, many questions. So, we'll try to respond to your questions, as many as possible. So the first one is, do you treat pre-diabetes with SGLT2 inhibitor? So is it possible to start SGLT2 inhibitor in pre or early diabetes? This was the question, probably in patients with other cardiovascular risk factors. So
I might answer
Professor
that.
Cooper? Yeah. Thank you.
The truth is, in pre-diabetes, there's no evidence that SGLT2 inhibitors would be useful from a glucose lowering point of view. It's interesting that the SGLT2 inhibitors particularly work in quite severely hyperglycemic patients where you promote a lot of glycosuria. So in the pre-diabetic, if anything, they're not particularly effective. However, if you're looking at the renal disease or the heart failure that might be seen in these people, we know that the non-diabetics respond from a cardiorenal point of view to those drugs. But preventing the development of diabetes, I don't think we have any positive data.
Thank you, Professor Cooper. Maybe you could go on with the second one. Actually, as SGLT2 inhibitor cause weight loss, are you going to give this drug to patients with low BMI?
Well, you can give these drugs to low BMI patients. There's data in the clinical trials that you will see a benefit on the diabetes. But interestingly, patients with normal BMI don't seem to get much weight loss with these drugs. Mm-hmm. And that fits in with their mode of action, which is primarily due to hyperglycemia. And interestingly, in patients with low BMI, where the diabetes might be quite insulin deficient, you have a risk here that you could actually tip them into ketoacidosis. So you've got to be, that's where you'd be more careful about the low BMI patient, where you think they're actually insulin deficient. But if they're not insulin deficient, but just have low BMI, you can carefully introduce these drugs.
Thank you. And I think you have to answer to this one also. Yeah. The question is, do you think the drop of eGFR at the beginning of treatment related to baseline eGFR? And when do you stop SGLT2 inhibitor if eGFR drop? And so I think he wants to, yes. Mm-hmm.
So if the eGFR is low, You would use the SGLT2 inhibitor maybe to prevent the progression of the renal disease. But if your main reason is for glucose lowering, so if you're a very elderly patient who has a low GFR of about 30 or 40, where it's probably related to age and it's not diabetic nephropathy, but you want to reduce the A1C, you'd probably use a safe drug such as a DPP-4 inhibitor, which will work, an agent such as linagliptin, where the GFR level will not influence the dose. You really use the SGLT2s in the low GFR patient for a specific renal benefit. Now, we still don't really approve them below about 45, but the credence data, the data that we are likely to get from EMPA-Kidney, where they're going down to 25, probably means that we are able to go lower if we're looking for a renal rather than a glucose reason to use the drug.
Okay, thank you, Professor. But actually, the many questions are actually on renal disease, so I think you have to answer.
Right.
Okay, yes. So there is a specific question to you, Dr. Professor Cooper. Thank you for your excellent lecture. Please share your experience to start SGLT2 inhibitor after hospitalization.
Yeah, so that's a good question. So in a patient who's acutely ill, like just using metformin, we tend not to use SGLT2 inhibitors because particularly after surgery or before surgery or in an acute illness, you might precipitate euglycemic ketoacidosis. But once the patient is stable, if they've gone home, let's say a week later, I would have no hesitation in restarting the drugs, just like we restart metformin.
Wow, yeah, excellent. And there is a very interesting question. Could we continue SGLT2 inhibitor for patients currently with COVID-19 in the stable stage? What do you think?
So fortunately, I'm from Australia, where we are probably one of the few countries, even though we are just about to go into a short lockdown in Melbourne, we've only got like 18 cases, and yet we still are going to a lockdown. Nevertheless, I would not say that I'm experienced enough to tell you what to do with COVID-19, but I would think in a stable patient, that would not be a reason not to use these agents. But many people with COVID-19 are not stable. And in that group, they would have to be in hospital. I would not be using SGLT2 inhibitors.
Okay. And well, as you are especially interested in kidney, there is another question. Any recent update for SGLT2 inhibitor benefit in IgA nephropathy?
Yes, so we have data from DAPA-HF that shows that the IgA nephropathy group responded similarly to the other non-diabetic renal diseases. So most of the renal diseases in DAPA-HF, and there's, I think, I'm not sure if it's published or about to be published, there is the IgA data. It's not as impressive as in diabetes, but it's still the same direction. So I think it's a drug worth doing, and we will get more data from the EMPA-Kidney study, which is also including non-diabetic renal disease. But we have the positive data with credence in diabetes. Now we have the DAPA-Kidney study, and we'll soon have EMPA-Kidney.
Okay. So there is a question about the result of EMPA-Kidney. What do you expect about the result?
Well, it's a good question. I think we'll learn more about the lower GFRs because we've got people down to 25. I think it'll be very beneficial. I think we're going to see the same as DAPA-Kidney benefits in non-diabetic renal disease. And we are very fortunate there will be a small number with type 1 diabetes, which I think is an important question. We are not allowed to approve them yet for type 1 diabetes, but they're clearly effective. And we may see some benefit on nephropathy in that group as well. So I think we're going to see more of what we've seen in the other studies, plus a few extra details. And we'll be even more confident about this class and the renal protection.
Thank you. And well, I think this question comes pretty often. So when you are prescribing SGLT2 inhibitor with heart failure, with edema, and already on diuretics, do you reduce the dose of diuretics when you add SGLT2 inhibitor in treatment?
No. So in actual fact, there's some recent data from the EMPA study, which was shown by Cosentino, which shows that in actual fact, the people that are on diuretics, including loop diuretics, did even better. So I think you need to be careful about volume status, But the effect of an SGLT2 inhibitor on volume is pretty modest. Very little there's no increase in catecholamines, not much increase in the plasma activity. These are weak diuretics. So I don't worry about using these agents with diuretics.
Yeah, sorry for too many questions, but this is the question that you have to answer. So in the patients on finerenone and SGLT2 inhibitor, what is the lowest blood pressure it could remain safe for patients with
Well,
your
we don't
experience?
really know. We know that there is a pending publication where the SGLT2 finerenone combination is discussed. I've only seen the data briefly, but there was no evidence of a major problem with respect to blood pressure.
Okay, so I'm going to ask the last question. So do you think this is the one of the questions. So do you think this reduction of metabolic risk factors of SGLT2 inhibitor is kind of a class effect, or do you think any one of the SGLT2 inhibitor is superior to others regarding this reduction of metabolic risk factors?
I think in terms of heart failure, all the drugs have shown almost identical results within a few percent of each other. And the I squared for heterogeneity is 0. So I think we can't say there's any difference. And the renal data, if you use the same endpoints for all 4 studies, you get a similar I squared of 0. So I think the real debate is what is the effect in people with or without cardiovascular disease in terms of cardiovascular events. And we've seen a pretty noisy set of results. EMPA-REG really did show the best result, but the truth is in EMPA reduced, that effect wasn't as impressive. So I would be a bit cautious about the cardiovascular events, but empagliflozin at the moment has the best results. But that would not be the main reason I would use the agent. I do think one of the advantages of empagliflozin and to a lesser extent ertugliflozin is that they have 2 doses. And although the dose response curve is pretty flat, the obese patient, particularly we see in the Caucasian, where they're over 100 kilos, we do see an extra benefit when you go to the higher dose, particularly in terms of weight loss. And there's usually a bit of an effect on hemoglobin A1C.
Professor Cooper, thank you so much for excellent answers. Okay. I think it's the time is up, so we have to end the session. Thank you, everyone, for being with us.
We do have some time. Sorry, we do have some time left. I think we can still continue. We will end the session. Actually, we have about half an hour still.
Oh, okay.
So we've done 10. So maybe I will pick out a few of the ones that are still open and address some of them and then ask you, Professor Ree, what you think. So the first question I'm being asked is about dialysis and type 2 diabetes. Well, if you don't have a filtering kidney, it's pretty hard to see how these drugs would work. So there really have been no studies of any consequence in that setting. And I would not at this stage consider this class of drugs in the dialysis population. At the moment, we can only go down to about 30 mils per minute with confidence. The next one is the combination of SGLT2s and GLP-1 agonists, actually they are, not antagonists. So what do you think, Professor Reed? Do you think there's a role for that combination?
SGLT2, so SGLT2 inhibitor and
GLP-1 receptor agonist.
Oh, wow. Yes,
are they worth considering, particularly with weight loss?
Yes, right. For both. And there is and I have some experience because actually the insurance is not covered in Korea, but without insurance coverage, I'm actually using SGLT2 inhibitor with GLP-1 receptor agonist. And I think it's showing pretty good result, but there is a meta-analysis recently published, but actually they looked at around 4 studies that were published combining these drugs, but actually did not show that much reduction in body weight and not so well reduction in glycemic control, but we have to see more data to come out.
I think that will have to be specifically studied. I think that will become an important question, and hopefully someone will do it. There is some data with AstraZeneca where they've used exenatide and dapagliflozin and seeing benefits with Bydureon.
Okay.
So then the next question is, what about if you don't see a reduction in albuminuria after SGLT2 inhibitors? Should you stop the drug? Well, you're treating more than albuminuria, so clearly the A1C and blood pressure will be beneficial. Furthermore, there are some data from the Dutch group that there are a group of people that don't drop their urinary albumin with ACE inhibitors, tend to be the same people that don't respond to the SGLT2 inhibitor. And this probably indicates some renal hemodynamic effect that may not be seen in some people. So if the SGLT2 inhibitor is being used to reduce albuminuria and it doesn't work, you could stop it. But you might get a surprise, and what you've done is actually blocked the rise in albuminuria, which is a natural history. And if that happened, once you stopped it, you could always restart it.
So also there is a question about sick days. So do you have to stop SGLT2 inhibitor?
Yes,
or
you do. You do. It's like metformin.
Okay.
You need to really do. You really do need to stop it.
Exactly. Yes, and there is a question about the use of a combination of aspirin in type 2 diabetes in the prevention of MACE. Well, this is not.
Well, I think the data on aspirin and diabetes is still very messy. There are some data that you need higher doses of aspirin to reduce the platelet hyperreactivity that is seen in diabetes. But this has really been very poorly studied. Most of the data from very old studies.
And what do you think about diabetes prevention for SGLT2 inhibitor? Diabetes prevention effects?
I mentioned this earlier. There's no data. And theoretically, it shouldn't really do much because you need to have glycosuria and you need to be stopping that. And in pre-diabetics, you don't really see such a great effect. Interestingly, there's been an analysis looking at DPP4s versus SGLT2s, and although they have a similar average reduction in A1C of about 0.7, if you actually look at the data in more detail, the SGLT2s do very well at very poorly controlled patients, whereas the DPP4 inhibitors work better in the mild patients. And this justifies what we haven't talked about tonight, is the combination, which is a very sensible combination that should be considered, particularly if you don't want to use an injectable.
Okay. Well, to start SGLT2 inhibitor after acute coronary syndrome in type 2 diabetes, it's
Which
one
syndrome,
of the questions.
Sorry?
Acute coronary syndrome. Acute coronary syndrome.
Oh, acute coronary syndrome. So we would probably wait till the patient is stable. I don't think you would want, particularly if they're very unstable, I think you'd be worried about. But if you're in a hospital setting where you can monitor the patients carefully and you check for ketones, I think you can do it.
Well, there are many questions regarding the eGFR when you're using a SGLT2 inhibitor. So are there specific time points we need to pay attention during the eGFR drop?
That's a good question. I think what happens is if it's under 45, we now know that there are data to suggest they work. What we don't know what to do is if you've got a patient at 32 and then it's 26, what you should do. And my own impression is that I wouldn't stop them if there's no reason to stop them, because it's likely that they are renoprotective at the lower GFRs and we just don't have the data. And if you stop them, you might, even at 25, if you can slow them down, you will significantly delay the requirement for dialysis or transplantation. We will learn more when we see the EMPA kidney, but I'm in generally keeping the patients on these agents when the GFR drops below 30.
Okay, so, and there's another question regarding how frequently you should check eGFR or renal profile when you're prescribing SGLT2 inhibitor.
So there is a risk, or there is a risk like in ACE inhibitor, if they've got bilateral renal artery stenosis, you could tip them to acute renal failure. So in a patient where you're worried about that possibility, I would definitely do a creatinine within 1 to 2 weeks. But in general, I don't, unless there's anything suspicious, I would just do my routine measurements of creatinine that I would do in a normal diabetic patient with or without renal disease.
Okay, sorry for another question, but there's a question about titrating the dose of SGLT2 inhibitor in patients with kidney disease, because there
there's no evidence. There's no evidence that the two different doses have much of an impact on renal disease. So I would not double or triple the dose of empagliflozin from 10 to 25 for a renal outcome. Because if you look at the EMPA-REG data, where they've got a lot of data of the 2 doses, they're on top of each other. However, if I wanted to achieve better hemoglobin A1C in a very overweight patient, I would give it a go at the higher dose.
Okay, thank you. Here are some questions regarding not so irrelevant thing. So I think we covered most of the questions.
I think we've covered a lot.
Yes, thank you. Yes. Professor Cooper, thank you so much. You've been an excellent speaker and also an excellent clinician for, answering for these questions.
Thank you
can we, thank you very much. So can we end it up now?
Yes. Thank you very much, Prof. Ree. Thank you, Prof. Cooper. Thank you so much for your time. Thank you all for attending. We would just like to remind everyone that we will be having our next webinar on 12th of August, and the host country here would be Philippines. So please do join us for the next in the Connect and Protect series. Thank you so much, and good night, everybody.
Thank you. Bye-bye.
Bye.
Bye.